Good morning, everyone. It's a pleasure to be with you today to talk about some of the exciting new developments in prevention technology. So when we think about trying to prevent any infectious disease, we can think about strategies to decrease the source of the infection, strategies to alter host susceptibility, and strategies to alter behaviors that put individuals at risk for exposure. In the case of the modern technologies that are now evolving, we also have to pay attention to adherence. But it's also important to think of this not as three separate buckets as a false trichotomy, but these areas are inextricably interwoven. We have to pay attention to intended and unintended consequences of the rollout of new technologies, and to be aware that all the behaviors are embedded in a social and cultural, political, structural context. HIV transmission prevention is not an individual issue, it's a societal issue that we have to attend to. So today I'd like to talk about some new areas of prevention technologies. The first question we have to address in the current era of treatment as prevention, the rollout of antiretroviral therapy, and the exciting data that in many countries there's a decrease in HIV incidence, isn't treatment expansion sufficient? The other reality we have is that we do have proof of concept now that chemoprophylaxis, that pre-exposure prophylaxis works. So we do know that we have something additionally that will help attenuate the epidemic, but there are certainly many questions about how to optimize delivery. There are new pills, new rings, films, and injectables, and what benefits and what challenges might they offer? The whole concept of multi-purpose technology needs more discussion as well. We heard much about vaccines and the potential for immunoprophylaxis, and this has to be part of the new prevention equation. We also are living in an information era where we need to think about how we can best harness new information technologies to enhance HIV prevention. There are other approaches, such as circumcision, that may be able to move into new era as well because of new technological developments. And we should pay attention to the opportunities for combination prevention for people who use drugs. But this will not be cheap, and we have to pay attention to the cost of success versus the status quo, and realize that this is about expanding individual choices so that one size will not fit all. So to address the first question about why not just focus on treatment, this slide shows analysis conducted by John Stover and the Futures Group, and basically it said what would happen if we were able to rapidly achieve the goal of getting everyone with CD4 counts of 500 cells or less on antiretroviral therapy globally. That would mean more than 10 million additional people on antiretroviral therapy, and even in the best case projections, you can see mapping out to 2025, still getting more than 500,000 new infections a year occurring, so that by itself, treatment expansion is not necessarily going to be sufficient if we really want to arrest the epidemic as soon as possible. So we have proof of concept that antiretroviral therapy prophylaxis works. This nice depiction by Dr. Salim Karim of the 6 major efficacy trials basically says adherence is the major predictor of the efficacy seen, whether it was oral or topical tenofovir-based chemoprophylaxis. So it's adherence, 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 yet there are other issues that we have to pay attention to. Cultural work has certainly suggested that in the 2 studies that were not successful in showing efficacy, FemPrep and Voice, that there were participants who were interested in the studies but not necessarily interested in PrEP. And we really have to pay attention to that. Some of this may be medical mistrust, and therefore community education, really understanding what people want may be part of it. The other set of issues have to do with pharmacology. There may be less forgiveness for less than perfect adherence for drugs that do not achieve as high concentrations in cervicovaginal secretions as in rectal secretions. And Dr. Karim's group has also looked at the role of genital tract inflammation in the CAPRISA study and suggested that ongoing genital tract inflammation, which could be due to sexually transmitted infections, and perhaps in some settings, sexual violence, traumatic sex, might also attenuate the benefits of some of the approaches with antiretroviral therapy for prevention. But what we do know is that high levels of adherence are achievable. Robert Grant presented the data from the IPREX open label extension study earlier this week and found that the individuals who were particularly high risk for HIV infection also were quite adherent when they elected to take chemoprophylaxis, when they knew what they were getting, as opposed to being in a randomized controlled trial. Stephanie Cohen and Al Liu with colleagues in an IPREX demonstration project in San Francisco, Miami, Washington, D.C. have found that the majority of people who were told you can be monitored or you can start PrEP elected to take PrEP, and the majority of those individuals had levels consistent with at least every other day use of the medication. So we do know that oral prophylaxis may be an appropriate strategy for some individuals, but it obviously involves individual education and ongoing support for adherence. So there are a variety of different strategies that we can undertake to improve chemoprophylaxis effectiveness. There are two studies underway looking at whether less frequent dosing may be associated with higher levels of adherence. So the IPREGAY study, which Dr. Molina presented initial data from earlier this week, is looking at pericoital dosing in men who have sex with men. HPTN-067, led by Dr. Grant, is looking at the issue of both pericoital dosing versus fixed interval dosing. If I tend to party on the weekend, am I going to be more adherent if I know to take medication on Friday and Monday with potential extra dose? These kinds of questions are extremely important in understanding human behavior. But there are other medications under study at the present time, which we'll talk about. Some oral medications like Maraviroc in the HPTN-069 study. Topical gels, both vaginal and rectal, are under study. Intravaginal rings offer some new possibilities for co-formulation with hormonal contraception, as well as injectable agents, and there are injectable antiretrovirals, but also injectable monoclonal antibodies, which overlaps with our prior talk. And then we have to think about how to use the new strategies to optimize adherence. So in terms of the priorities for new technology, for some individuals, an on-demand product would be ideal. In the Caprisa study, individuals were protected who were asked to take a dose before and after intercourse. And for individuals who are not necessarily going to be able to plan when they may be at risk for HIV, this may be a very important approach. On the other hand, for some individuals, remembering to take a pill may be more challenging, so products like a ring might be able to be inserted as infrequently as once a month or even less often. Injectables similarly may be able to offer individuals the opportunity not to have to worry about taking medication on a daily basis. When we talk about multi-purpose technologies, we already have excellent multi-purpose technology. It's called the condom. There are male condoms, there are female condoms, and there are further elaborations that are going on to make them better tolerated, to make them more satisfying sexually for individuals. And certainly, we're not talking about new technologies to abandon these old technologies, but we know that in many parts of the world and in many communities, this is not necessarily the most acceptable means by which individuals may want to be engaging in intercourse. So that's why we need to think about drug combinations, different kinds of devices, injectables, and new technologies such as nanofibers. Nanofibers are very similar to the kind of Listerine breath mints that people may be familiar with. So the question about whether a film which would be able to be kept in a small receptacle that could be inserted and then melt and deliver a high dose of antiretrovirals is another approach, another technology. So in terms of on-demand products, the one that we know the most about so far is tenofovir gel. In the Caprisa study, was effective in protecting at-risk women against HIV as well as herpes simplex virus type 2, but not in voice, which was a daily gel use study. There's a confirmatory study underway, and we'll be very excited to see the results of that study within the next year. There's also work going on to optimize the tenofovir gel for rectal use. The vaginal gel in an initial study, MTN-006, was not found to be highly acceptable because it caused side effects associated with increased urge for defecation, not something you'd want to be feeling when you're considering using a lubricant for sexual intercourse. So the revised gel has been found to be highly acceptable in MTN-007, and now there is a phase 2 study underway which will be following 360 men who have sex with men and transgender women in Peru, South Africa, Thailand, and several sites in the United States. But there are other gels in earlier stages of development. MIV-150 with zinc acetate and levonorgestrel is being developed by the Population Council. This is an NNRTI. Grifocin is a compound that inhibits both GP120 and GP41 binding that is being studied at the present time as well. There are co-receptor blockers such as congeners of RANTES and as well as a new agent, P0528, which is both an NNRTI and entry blocker that will be entering human clinical trials shortly. Maraviroc is an oral CCR5 blocker that has extensive safety profile and is used for therapeutics. The idea of using an agent that would prevent the virus from entering cells has a great deal of appeal, and HP10069 has now enrolled 400 men and has almost fully enrolled 200 women, and will be following these individuals over the course of a year. This is a double-blinded study where every participant gets 3 pills, so they're either getting Maraviroc alone, Maraviroc plus tenofovir, Maraviroc plus FTC, or the comparator tenofovir FTC. And it's an assessment about which regimen is most tolerated. We'll also look at various pharmacologic parameters to see whether it would be appropriate for Maraviroc alone or in combination with other antiretrovirals to go forward in an efficacy study in the future. Maraviroc is also being developed as a topical gel and as well as a combination gel. In terms of the microbicidal rings, there's been a great deal of activity in recent years. Some of these rings may be able to be inserted for more than a month, for several months at a time. The newer rings are easy to use and are quite comfortable in the early work that has been done. And the manufacturing costs are relatively low and has the potential for delivering drug combinations. The compound that has undergone the most study as an antiretroviral embedded in an antiretroviral ring is ipivurine. This is an NNRTI. It's been developed initially as an oral therapeutic. The intellectual property was licensed to the International Partnership for Microbicides in 2004, and there have been extensive safety studies of this product. So there are now 2 efficacy studies underway in Africa, IPM027 and MTN020, the ASPIRE study. By 2016, we should have data on these 2 major studies, and we may then have proof of concept that a vaginal ring can protect women against HIV. There are multiple other studies underway now, such as studies in adolescents and extended PK studies that will give us additional information about how to best to use these rings. But there are next generation rings already coming into development and into study. One ring would be a 60-day ring that, for ipivurine that could be inserted as infrequently as that often, and this would contain levonorgestrel, so it would be able to protect against pregnancy. Additionally, Conrad is developing a 90-day tenofovir ring with levonorgestrel, and the Population Council is developing a ring with MIV 150 and zinc acetate and levonorgestrel. Additionally, there is the Nuva ring, which has been around since 2002, developed by Merck. This is a matrix, non-latex novel polymer, and there are 2 antiretroviral compounds that are also manufactured by Merck that are in early phase study to see whether either alone or in combination with the Nuva ring that this may be another approach for protection against both pregnancy and HIV. Another idea of an on-demand product would be a barrier protection that could also use one of the gels. The Silk's diaphragm is a new concept, which is a one-size-fits-most silicone diaphragm, so that it could be available over the counter. Its studies so far in terms of pregnancy protection are quite favorable, and so further studies are underway now to see whether it could be combined with tenofovir gel as a dual purpose that would only involve an antiretroviral but would protect as well against pregnancy. The field has moved very quickly into the studies of injectable antiretrovirals. There are 2 compounds that are now in phase 2 clinical trials in multiple centers. Rilpivirine has been developed and is already FDA approved as a combination component of a fixed dose combination in the drug called Complera. It potentially can be formulated to be quite long-acting, and so there are PK/PD studies, and there's a phase 2 study underway in the HIV Prevention Trials Network. Cabotegravir, formerly known as GSK744, is an integrase inhibitor. Structurally, it is similar to dolutegravir. It has been found to be safe in humans with an oral run-in and may again be able to be administered as infrequently as every 3 months. The non-human primate data are quite promising. There are 2 phase 2 studies, one underway and one that will soon be getting underway, evaluating this, so that if these studies continue to show safety, one can anticipate efficacy studies in the next year or 2. These data presented at CROI about cabotegravir, basically, if you look at the green arrows, there are 2 injections, and yet at 28 weeks, the levels were sufficiently higher than the anticipated concentration needed to protect adults, so that this certainly has the potential for quarterly dosing, and further studies are underway. The other potential advantage of these injectables are that they could be co-formulated or given at the same time with hormonal contraception, such as Depo-Provera. There are other medications that might be prophylactic against other infections that might be able to be given this way as well. So the question is are these products safe? That is being answered now. Soon we'll have data on whether they are effective, and we also will need to have data on the acceptability in different populations. We've heard an elegant talk in terms of the immunology that we need to understand to develop a vaccine, and there are a host of monoclonal antibodies that have been developed that can block specific stages of the HIV virus life cycle. I just want to give you one case study of how people are thinking about these monoclonal antibodies for their use for prevention. VRCO1 was isolated from a long-term non-progressor. This was the NIH's Vaccine Research Center. It's the first product that they had developed. It binds to HIV-1 GP120's envelope protein, quite protective in the non-human primate model, and had broad and potent neutralizing activity. So it certainly can inform the development of effective vaccine, but there also has been now phase 1 study that has been underway, and a second phase 1 study more recently initiated at the Vaccine Research Center to look at its safety, and there will be a study that will be beginning in the next month in multiple centers in the United States, evaluating whether this can be given subcutaneously or intravenously at various doses, and maybe this could be given as infrequently as every month. The next study that is being planned is through the IMPACT network to identify infants who are born to mothers in resource-limited settings where the mothers had been unaware of their HIV infection, so the infants are coming in at birth, and potentially instead of being given antiretroviral chemoprophylaxis, it's possible to either give in combination or instead of to give this monoclonal antibody to protect against HIV acquisition. The same question might apply for adults, as opposed to individuals coming in acutely after exposure and being asked to take a month, 28 days of antiretroviral medication. Perhaps a monoclonal antibody could be the post-exposure prophylaxis of the future. Other investigators are looking at this whole idea of the monoclonal antibodies and whether they can be given topically. So Dr. Deborah Anderson and colleagues have a grant which is a translational grant using plantibodies, so that taking the nicotine plant that's being bioengineered to produce VRCO1, harvesting that, purifying it, and then seeing whether this can offer topical protection against HIV. So the future of topical prophylaxis may not necessarily only involve antiretrovirals. There is an extensive pipeline. I call and commend for your attention going to the AVAC website, avac.org, who always keeps up on the cascade of new agents that are being developed. You can see under phase 4, right now we only have essentially post-marketing studies of tenofovir FTC. But if you look at the preclinical pipeline and the phase 1 pipeline, there are an extensive array of new compounds being developed that are both antiretroviral and immunoprophylactic, that may be given systemically, that may be given taken orally, or used topically. So there is certainly a lot to think about for the future. We also have to think about the use of e-technology. So we know that this is where people meet partners. You can see that screenshot of Grindr, and I would imagine that there may be a few people in the audience who might actually have this app on their cell phone, but don't use it right now. So these apps are GPS. They have GPS functionality, so one can identify where potential partners are in very close array, but there are a host of other ways that we might be able to use e-technology more effectively. SexPro is an application being developed by Dr. Susan Bookbinder and her colleagues as a combination prevention grant. So this would be an app that individuals could actually input material about their behavior and try to get a sense of their patterns of risk, and perhaps be offered focused prevention interventions based on what their current activities are. E-technology technology also offers many opportunities in terms of enhancing adherence to these products. One of the landmark papers in recent years, I think, was the paper by Lester and colleagues in Western Kenya, showing that having regular contact with patients by text messaging was associated with a statistically significant decrease in plasma HIV RNA, so improved adherence when there was regular contact with text messaging. There is a device called the Wise Pill that looks like a cell phone that essentially is a pill box, but it provides real-time signals to individuals when the pill box is open. And there's been work, Jessica Haber, Steve Safran and colleagues have used this successfully to enhance adherence interventions in some of the PrEP studies. And Life Steps is a behavioral intervention developed by Steve Safran and also now using SMS text messaging as part of the reinforcement. One can also have a regular dialogue and ask patients on a daily basis, have they engaged in risks, and be able to provide real-time reminders for individuals. Revea Miko developed Next Step Counseling, a technique that was used in the IPREX open label study, and a recent study looked at whether an electronic diary used in San Francisco and Chicago, whether that was associated with adherence, and definitely it was. Rafi Landowitz at UCLA is looking at whether giving feedback in real time on drug levels might also enhance medication adherence to prophylaxis. And Ariane van der Straten and colleagues have been looking at whether tag-ins or even pills that are tagged with information that would feed back in real time, that might have electronic sensors that would tell people when the pill was actually ingested. There also are lower tech approaches, such as home visits, which are important to keep in mind as well. But marrying the old technologies and the new technologies may allow us to be more capable in a more efficient way to assist our patients in maintaining optimal adherence. We've had an amazing amount of research done in a very short time to show that male circumcision decreases HIV incidence quite dramatically. So within 15 years, we've gone from epidemiologic studies to actual scale up with more than 6 million circumcisions done since the WHO and UNAIDS recommendations. And you can see in several countries, the pinkish color here is in Uganda, and the blue is South Africa, just the number of new circumcisions that have taken place in recent years. And the whole field of circumcision can benefit from new technologies as well. There is the pre-packs, which is WHO pre-qualified, and the Shang ring, which is in the process of being pre-qualified, and coming down the pike is Unicirc, and these are approaches that don't involve extensive surgery, that are less painful and more efficient. There also are lower technology approaches, such as being more mindful of having exam rooms going on at the same time, where procedures can be done in various stages with other health professionals besides the surgeon being in attendance for various steps of the procedure. So task shifting combined with some of the new technical approaches may be a way in which we can further scale up circumcision. We also have to pay attention to the needs of individuals who use drugs, and I stress that all of this has to be done in a voluntary, non-coercive way. Clearly, foundationally, voluntary counseling and testing are fundamental, and certainly access to clean needles and syringes are extremely important. But now we have new technologies in terms of opiate substitution therapy, where medications can be given as frequently as once a month, and possibly soon even less frequently. And you can consider adding to that access to antiretroviral therapy, or for those individuals who are not HIV infected, consideration of access to PrEP is something that deserves further study. You can see here data from Rick Altista and colleagues that the combination of buprenorphine, or now extended action naltrexone, in combination with culturally competent care is associated with high rates of virologic suppression for people who are using drugs. And this is, again, another important area of the new technology. So many have said, this is all well and good, these are very exciting new approaches, but you're really spending a lot of money for people who are not HIV infected when resources are so constrained. This analysis, initially presented by David Glidden at Croy this year, and just written up recently by Susan Bookbinder, plots the HIV incidence rate that was seen in different clinical trials of PrEP, and looks at the number needed to treat in the y-axis. So you can see here, for example, in the Caprisa study at the far end, You can see here that the number needed to treat is quite modest, 25, 30 women needing to be on PrEP to prevent one new HIV infection. And that's because, unfortunately, the HIV incidence in KwaZulu-Natal in the control group was so exceedingly high at 9% per year. Comparable efficacy you can see here at the Tenofovir Bangkok IDU study, but a huge number needed to treat because HIV incidence in the setting of being offered methadone was extremely low. So individuals may say, gee, you know, there's a lot of people you need to treat in this middle range of the studies that had middle level of efficacy, even Partners PrEP, which was highly efficacious, you know, more than 50, more than 70 individuals you need to treat to be able to prevent one infection. But I think it's important for us as a society and us as activists and advocates to actually pay attention to the fact there are health conditions where we are very willing to treat a lot of people to prevent one event. So if you look here at statins to prevent a cardiovascular or cerebrovascular event, 250 people going on statins, which have a cost, which have some morbidity, to prevent one of these untoward events. So is the society wanting to prioritize this or wanting to prioritize arresting HIV spread? Another way of looking at this, my colleague Rochelle Walensky plotted the data in terms of the efficacy and the HIV incidence for a CAPRISA study, for IPREX, and then the average incidence for young adults in South Africa. And you can see that if we can decrease drug costs, you can see that they are in the very cost-effective for South Africa area, the orange area, and this will expand if we can also decrease program costs. So more efficiencies in terms of the economics of the delivery of PrEP will make it a much more effective strategy in the long run. But there's another elephant in the room where we have to think about new technology, and that is the issue of who is going to provide prophylaxis. A colleague, Doug Krakauer, coined the term the purview paradox, and this is the contradictory set of beliefs that providers have about who should be prescribing PrEP. And this is based on work done interviewing providers in Massachusetts, a place where some of the early PrEP studies were done. There's access to care, a liberal social environment. And so HIV providers basically said, primary providers are the best people to provide PrEP because I take care of people living with HIV. I'm not taking care of people who are HIV uninfected. Primary care providers said, I'm certainly willing to talk to my patients about their sexual behavior, but you know, I don't really have a good feel for using these antiretroviral medications. So there's a lot of this going on, pointing the fingers to each other and not figuring out who's going to do what. I think there are some opportunities with some of the newer technologies to really get beyond this. So Dawn Smith from the CDC looked at several of the cohort studies which had HIV incidence estimates for men who have sex with men, and developed a screener where with a set of 7 questions and assigning various point averages, there was a pretty good predictive value of who might benefit from PrEP. So a score of 9 or 10 could suggest that somebody might benefit from PrEP. And Heidi Crane at the University of Washington has developed a technology called ePro, Electronic Patient Reported Outcomes. So at 8 of the CNIC sites around the United States, taking care of 30,000 people living with HIV, twice a year individuals do a self-screening interview that takes between 5 and 10 minutes that can ask questions that are quite sensitive. And that information gets transmitted directly electronically into the electronic health records. So I think starting to think about how to use heuristics like the ones that Dawn Smith has developed and using electronic screening may allow for more regular assessment of individuals' risk and who might benefit from PrEP and who might not. But we can't lose sight of the fact that this is not something about individuals. We know that obviously giving people access to the new technology is extremely important, but the reasons why people may be at risk for HIV may relate to relationship issues and power dynamics, but also relate to community issues. And we certainly know that this global epidemic has many social determinants that have to be addressed, and we can't just be blasé or glib about the advent of new technologies being the simple fix. So we have to think also about policy and structural issues if we're really going to get a handle on curtailing the spread of HIV. And we are living in an era of constrained resources. For those who are very interested in this area, I highly recommend this website, HIV Resource Tracking. And you can see here the overall curve is quite depressing to my mind. The fact that over the past 7 years, we're basically at a flat level, particularly when you think about adjustment for inflation. Some things have been really that have had lot less funding for in more recent years, such as microbicides. Others, such as vaccines, funding has gone down a bit, but has been fairly stable. There has been more funding for studying treatment as prevention, as well it should, but I think we all can agree here that we'd like to see this line go up and not stay flat or tend to go down if we really want to take advantage of all the exciting new developments in recent years. So where are we today? PrEP works when used, so that's extremely important. But new meds and dosing regimens for oral PrEP may improve uptake, may decrease costs. So if we can think about how to be more parsimonious, or whether we can identify agents that can be used more effectively, that's very important. VAX 001 success may be a major game changer, because this would mean that a gel would have been corroborated to be effective in two studies, and this would lead towards licensure, hopefully in many jurisdictions. Rectal gels may also offer better penetration for individuals who engage in anal intercourse, men who have sex with men, transgender women, heterosexuals who engage in anal intercourse. Rings may offer multi-purpose technology, prevention approaches, as well as injectables. Uptake of circumcision remains to be important, and harm reduction using state-of-the-art approaches for those who inject drugs is extremely important as well. And we have to think about how we optimize social media in order to facilitate safer sex counseling and adherence. But this doesn't mean that we give up on vaccine and cure research. These are still our holy grails. So increased investments are needed, increased political will is needed, commitment for human rights is essential if we're going to make any progress. I want leave you with the thought that I've talked about a lot of exciting things. These are not bright shining objects or silver bullets, but if we attend to these things, we may be able to achieve that end of the epidemic that we look for. I want to thank my colleagues at Fenway, and I also want to thank all the many colleagues who've provided input and the funders. And I particularly miss and want to honor Joep Lange, who was somebody who very early on, as a treatment expert, really understood the potential potency of the use of antiretrovirals and other approaches for prevention. Thank you for your attention.